Thank you very much, everyone, for coming, and there are quite a few people in Zoom too. Thank you all, Zoom people also, for coming in. Uh, Today, actually, I'm very pleased to introduce Dr. Anjana Pokharel, today's speaker of our colloquium from Tribhuvan University, Kathmandu, Nepal. She's a professor there. Uh, Today, and actually, she is the recipient of this American Mathematical Society. That's the certain grant funding provided for the students of developing countries. She is the recipient of that. And in terms of degree, she just finished PhD in mathematics from Tribhuvan University. And of course, she had master's, MPhil, all undergraduate degree, also from Tribhuvan University. And she's working in the disease modeling. This part I'm not going to talk too much because she's going to explain. The more than that, I would like to mention one thing, introduce her not as a student, as an inspirational idol. Because during this PhD program, when we were actually continuously collaboratively doing work, we used to do through the Zoom. And during your doing PhD program, she was diagnosed with cancer. And she had to go through the so many chemos. And from not from Nepal, she had to flew to Delhi. And in Delhi, she had to spend lots of time, almost 2 years actually, she had to go through the treatment. But one inspirational figure, she never actually her motivation, inspiration, it was never down, it was even more during treatment. And we know through the Zoom, I remember she even attended our regular meetings from chemotherapy in Delhi. So that's why during that time or immediately after that time. So that's why she's really inspiration, and she is now cancer free, and she has successfully defended PhD and completed it. So I also want to present her as an idol. Anyway, so this she will be talking today about modeling measles transmission dynamics in adults and children in Nepal, implications for eradication and control through monitored vaccination studies. Okay, Dr. Pokharel, it's all yours. That's the pointer. The red one. Yeah. Pointer? Is there a pointer? Red
Should
one?
be the red.
Red one.
Yeah.
Oh, yeah. Let's go. So maybe.
Is it clean?
Oh, there. Yeah.
Just one
It's
thing
okay.
over there, okay?
Thank
You would fit.
Thank you. It's my honor to be here, please. I'm so glad here now. Thank you for introducing me such a wonderful words also. And now, actually, I'm incredibly fortunate having such a wonderful, supportive, and encouraging guys as my supervisors. That's why I came here right now. This is my fortunate. And now it's in this work, actually, this is my work during the PhD research. We have done this as we developed the two models with the modeling with the transmission dynamics of measles. And now there are some outlines for these talks, some motivations and our work with developing our models, two different models and conclusions, and then some references too. And actually, this is about the motivation towards the models, measles. There are some screenshots of the newspaper published in Nepal showing that the difference, showing that the outbreaks of the measles outbreak in the different parts of the country, even though it is going to eradicate, and WHO has a great concern to eradicate there also. And this is the global status of measles cases here also. Why not the sky blue color is in the case in US too here. Still, there is the small. This one is about the US cases. And this is the cases in Nepal from the 18, 19, and 20. This was such a rising case in Nepal, even though this is the vaccine preventable disease. And despite all these conditions, despite all these outbreaks, there are so many activities from with the anti-vaccine activities. These are some screenshots showing that the activities by the anti-vaccine vaxxers. And also there are some cases unvaccinated population. Still there are, even though in US, these are the unvaccinated population throughout the 10 to 17. This is, and also these are also developed countries also has such type of unvaccinated population. This is the interesting things here. And about a little bit information about the measles, it is very common disease in child disease. It is highly contagious viral human disease. It is caused by marinovirus. Virus transmission has very high, over 90%, even though since it infects more than about 5 to 18 others people, individuals. And one interesting thing is that one attacks of the disease, it provides lifelong immunity to individuals. And as concerning such type of disease, WHO as especially WHO announced the goal to eradicate the disease by 2019, in 2013, which could not achieve at that time, and extended to 2030 and later, which still now it also extended to 2030. Therefore, this is very problematic cases array. And this is actually vaccine preventable disease. We need to know that this is the 2 doses of 2 sorts of vaccines at the age of 9 months and the 15 months. And this is regular vaccines. And now we developed this, among this situation, we developed this model introducing our monitor vaccination model, and which the result is published in this paper. And for this case, in particularly in Nepal, this is the case of Nepal now throughout 7 to 15, especially supplementary immunization activities was due to such activities, the cases was declined at that time, but later on it began to rise after 17 and still now. And the frequent outbreaks especially in the low vaccine coverage area, whereas the 95% of the children were not vaccinated till now. And even in vaccinated people, the protection level may be reduced due to improper vaccination, timing, and incomplete doses. And now we developed such type of model where the susceptible population, that means which can be infected by the disease and recruited by birth, it can be increased by birth, and the view is the natural death rate, and the susceptible when contact to the infected people. The susceptible when contact with the infected peoples, they might infect the individuals, and this E also the infected population. But here is the E is symbolized here as stand for as is the infected, but cannot transfer the disease. That is not, this E is not infectious. That means E cannot transmit the disease to other peoples. Only E is infected, and I is infected and also can transmit the disease to others. When it contact to the susceptible, then these can infect. And when after recovery of I, infected people, they are immunized. Therefore, especially somewhere this is as the recovered people, and what we have written, we have symbolized it as the immunized peoples, immunized since the lifelong immunization they get. And another things, the way the susceptible peoples are, there are some regular vaccination program in country, In such a case, we divide this. Most of the people, all the peoples may not go to the vaccination. Some skipped some skipped people. They who skipped the regular vaccination. They we introduce for those individuals. We introduce as a monitor vaccination to monitor the vaccination for them who skip the regular vaccination. Therefore, all UV stand for the regular vaccination who wants to go for themselves. They do not need for another force or another agents. They can do themselves. And but they are not monitored. They sometimes go in the time and they sometimes lose in the time. They sometimes if the 9 months of the first dose, they may start with the first dose and later on they may skip or lose the second dose too. And in that case, such type of peoples may have infected in that period, and they also infected, and with this rate, this beta I by n, and this is epsilon y is as the effectiveness of the vaccination, and they can be infected. And similarly, they immunize at the rate of gamma 1, and the MB that stands for the monitor vaccination are also they may also be infected in the period of 9 to 15 months. That's why this is the alpha. This is the they can also infected at this rate. And we assume that they are immunized with the rate of gamma 2, and all these are also immunized. And such we developed the model in the basic of SEIR, the basic model introducing the unvaccinated and monitor vaccination program. And these are the equations developed from this model, the rate of change of susceptible, and all these are the six equations we developed here. And we fitted this model to our real data. This is our validation to our data, since the data is published by WHO from 2000 to 2019. There were 20 points data, and by using this data, we fitted the model, and now the incidence case. This is our incidence case. Therefore, we use this is sigma E of the incidence case. We use this function and model prediction. We define this function as a model prediction and as sigma t, and we fit it to our data. And with we also estimate our parameters with the help of the nonlinear regression methods, minimizing the square residuals, where this is one is for data points and another is from the our model prediction points. And this is our fitting, and these are the incidence case. These are the incidence points, and this solid line is our model prediction line. And by taking this is the best fit parameters, we can get this, and by using this one also, this cumulative data will also fit. We also can be on this we along the cumulative points also, and we obtain these parameters from the fitting parameter estimation from the fitting, and somewhere we use we also assume, and someone are taken from the references. And for the validity, we also check the positiveness of the positivity and boundedness, since all these variables are populations. Therefore, it cannot be negative. So by using this relation, this solution, we show that the populations are all these solutions are non-negative at any time. That's why these are ordinary differential equations, nonlinear equations give the solution non-negative solutions every time. And we analyze them mathematically for this we analyze as equilibrium analysis and stability and uniform persistency too. And as we obtain the equilibrium analysis, we obtain the 2 points, as one is with the presence of disease-free equilibrium point, with the presence of disease-free, that is the disease-free equilibrium point. In this situation, this E is with the class is infected with the disease and I is also with the disease, and others are non-disease, but there is interesting things that only 2 are zeros, are zero, others all these are, or other 4 variables are non-zero. Therefore, it becomes a little bit complicated to analyze mathematically. And if you have, please, if you have anything, you can have some questions here also, if you have, please. And in this case, what about the stability of the disease-free equilibrium point? For this, we need some basic reproduction number. Therefore, the basic reproduction number, often denoted, this represents the average number of the secondary infections that is produced by a single infected individual in a full susceptible population throughout its infectious periods. But whereas in our cases, our population is mixed up with the vaccinated population. Therefore, we obtain here the vaccinated reproduction number. We denote it by RV. And as we obtain, this is our expression for the RV and also effective reproduction number, whereas this is at the situation of the disease-free equilibrium point. The RV is actually calculated in the disease-free equilibrium point, but over time the population changes and the effective reproduction number also changes, and this is the expression for the effective reproduction number, whereas the basic reproduction number or the vaccinated reproduction number is a fixed number and it is changed over the time. And we also prove for this proof of the stability of the disease-free equilibrium point, we prove it as locally, asymptotically stable and also globally stable for the case that RV is less than 1. But what is the meaning of the epidemiology? What is the meaning of in epidemiology about the stability of the disease-free equilibrium points? This means, as in this case, the local asymptotically stability, that means when the disease dynamics initiated with a small number of infection that is introduced in the community approaches to the disease-free equilibrium, to the same disease-free equilibrium point over the time of RV is less than 1. When the situation is RV is less than 1, the disease always approaches to the situation disease-free equilibrium point. And conversely, if the RV is less than, that means if the basic reproduction number is less than 1, that means in the situation that disease outbreak will die out when a small population occurs with the introduction of a small number of infection, which is usually the situation of the beginning of the disease. And from this situation, we can say that this situation allows us to design a vaccination policy that assures that RV is less than 1, thereby avoiding the outbreak and does not ensure outbreak in control under all conditions. That means we want to keep the situation that always RV is less than 1. That is the situation of that disease may die out. Therefore, we'll try to maintain this one. Therefore, this is the situation for the disease diet. And another is, what is the meaning of global stability in the epidemic? That means, this means the disease cannot establish that sustained transmission within the population for any even significantly large initial number, making that initial number of the infection as long as RV is less than 1. Till RV is less than 1, whatever the population, it doesn't matter, the disease may die out. And so this relation, this condition may help to maintain and implement the preventive strategy, such as vaccination programs for the disease control. This is the main part. This is one fact to make the disease to die out. And there is another things that when disease is there, we obtain the equilibrium point, that means steady state, that is the disease free. And if there is the presence of disease, there may also sometimes stable, that means endemic, the equilibrium point there may also. That means the existence of the epidemic equilibrium point, we also obtain that there is at least 1 point. We obtain there is at least 1 point for RV is less than, for RV is greater than 1. We obtain one endemic point, but I could not express all these reasons since it becomes a very long expression. And it proved that the system is, we also proved that it is uniformly persistent. That means the disease is endemic for the over the time RV is greater than 1. And we skip to the numerical analysis. We have done some. Now this is the basic dynamics as we did an effective reproduction number for measles endemic in Nepal. This one, it shows that this is the curve of effective reproduction number. It shows that the RT is, this is the line for RT is equals to 1. And when this effective reproduction number is RT is less than 1, that means the disease is going to decrease. It does not show other things, just it shows that the trend of the disease decreasing or increasing only. And when the RT is greater than 1, the disease is increasing. Therefore, this is the situation we can say that until 2030, the disease is going to decrease. After this one, it's going to increase up until 2095. This is the prediction from our analysis here. And now, we saw this long-term dynamics as we study this one. This is showing that this is the case that still there are a few cases are here still, but even though this is a low level of disease still remains here. After that, it is also goes to increase here and obtain a straight line about almost as a steady line. Therefore, we can say that in 2023 there were 178 cases, and low after 33 it persists in low level, and after 33 the resurgency of the outbreak will begin and reach the peak value when 2097. This is the peak value, and 23rd we have already passed, but we can see our data is almost correct at that time. Not so, our prediction is almost correct. And this is the case that the infection from the susceptible and unmonitored vaccination, and this is monitor vaccination. It shows that the infection has the great role for the contribution with the susceptible and the unmonitored vaccination there. Now we also test the sensitivity analysis of the parameters to our basic reproduction number, that means vaccinated reproduction number, and we obtain the RV, the sensitivity index, and as well as the global sensitivity it is by using the Latin hypercube sampling. And these are it shows that the beta is the highly highly sensitive here now for the R0. And similarly, here is also E epsilon 1. It shows that the global sensitivity, in the case of global sensitivity, epsilon 1 is the likely. And similarly, here are we also obtain the sensitivity analysis of dynamics at peak and peak time. That means when which parameters are sensitive, which parameters influence for the peak dynamics, peak infectious points, and which parameters are influenced to the peak time. That means which one is this? Just like beta is highly sensitive for the peak time. That means when beta rises, the peak time will be in the short period. That means quickly the infected case may be and these are the effects of the vaccination. We also obtained we compare as this one. This is the line of RV is equals to 1, and we try to get the condition for this RV is less than 1. This is the condition we want here. For this situation, what is the combination of alpha 1 and epsilon 1? This is the situation. From this, we can obtain the condition to die out the disease, to reduce the disease, or to control the disease. And similarly, this is the case for gamma 1 and gamma 2. That means the immunization of monitor and non-monitor vaccination. And similarly, epsilon and epsilon 2, that means the effectiveness of the vaccines. And this one to the on-monitor and monitor vaccinations. And here are also the effects, the effects of the vaccination on the dynamics. That means we observe that what will be the situation if there is no monitor vaccination, if the monitor vaccination is double, if the monitor vaccination is half, what will be the situation? We observe this one. And similarly, this is the situation for gamma 1. That means the immunization of the on-monitor vaccination, and this is the effectiveness of the on-monitor vaccination, and this is the effectiveness of this is the rate of on-monitor vaccination. And this is the study effects of the vaccination on the study. It says that when the study says what will be the situation of what will be the cases, how much cases will be there at the situation of steady states if the disease remains, that this is the situation of that. Therefore, this is what will be the situation for alpha 2, this is for alpha 1, and this is for gamma 1. Similarly, we also observe this one, and we obtain that these are the situation case at the steady state for the various vaccination rates. This one, that immunized rate and effectiveness of on-monitor and monitor vaccination program, epsilon 1, and these are all this makes the situation steady state. So how we make this one is, this is the condition of the disease. Normal, then this is not out of the disease. And we obtain this conclusion from all these first parts. Our model shows the vaccinated reproduction number, which is slightly greater than 1. It shows that the endemic, the disease occur for a long time, even though it is in a small number, which is also demonstrated by our result too. And the global stability of the disease-free equilibrium point implies that if the disease die out once, maintaining the situation, keeping that RV is less than 1 by the vaccination and monitor vaccination, that program will control further outbreaks of the disease. The disease would have been eliminated by 2019. That is the case at last first deadline by WHO to eradicate the disease, which could not be as if. Therefore, at that time, if the disease would have been eliminated by this one, had the regular vaccination program increased by 12.5% or the monitor vaccination by this one. And this model predicts the major contributor to the measles resurgence in Nepal is susceptible and on-monitor vaccinated groups. Definitely this one, we have also seen this one emphasizing the need for the expectation of monitor vaccination programs. From these results, from this research, we could say that we need monitor vaccination program, then we can control the disease. And we developed the next model as the adult child vaccination model, and which the result is published in this paper. For this among this scenario about with this background, that means after the COVID pandemic, the immunization program is declined, and due to which the about 25 million children missed at least one measles vaccine dose. Those 71% the full dose and 81% of the first dose by the first birthday. This is the condition after due to the pandemic. And in particularly in Nepal, this is not for exactly the Nepal, this is about the global data. And this is in Nepal, January to April in 2020, there were these cases in which the 78% affecting individuals of outside the targeted age. Our targeted age of vaccination is 9 to 59 months. Therefore, at that time, they skipped, the program was disrupted and it cannot be immunized. Therefore, of these disturbances of these immunization programs, the 60% of cases in the 5 to 15 years had not vaccinated at that time. And November of 24 to 22, this one to March 10, 23rd, 23rd, there were 690 cases. Among these, 86% affecting individuals aged less than 15%. And 15%, 58% were unvaccinated. And it shows that there were 14% are affecting, 14% are adults infected at that time.
I have a question.
Yes, please.
Your study was focused mostly in Nepal.
Yeah.
Right? So, have you tested a model with data from other countries? Because, for example, like I actually read about this and I was surprised that there was a resurgence, let's say, of measles. And one question that I have that I maybe is there something that happens, like, for example, I don't know, Nepal or in particular places, or this is something that is worldwide? When I say worldwide, like every region of the globe, you can identify a resurgence.
Thank you for this questions right now. Since actually this is the situation we have targeted, that there are the situation of the vaccinated peoples are also skipped. Since the measles is vaccine preventable disease, though there is, despite the availability of the vaccines, the outbreaks is rising cases. Then what is the cases? Why the such type of measles cases rises? That means there are some situations where the individuals are not vaccinated. Actually, the unvaccinated, we have seen here, unvaccinated people are infected. That's why your question, as I understanding your question, this model can also be used to other model, other data also, where such type of situation will be there. Just like as in US too, I think the data, if available here, we can also do the same thing. Since here are also the monitor vaccination we can introduce, as well as the regular vaccinations here. So many people are also without the protest the vaccination program. That's why that is the importance, I think so, please.
Well, quite a few, because my understanding is that if you get infected, you're immune. Right? That's immune. You don't get it.
Immune, yeah, immune.
So, and I have no idea if people die or how many people die, what percentage of people who get measles die. Like, when I grew up, I never could believe that somebody will die by getting measles. Okay? So that's one. And I understand about the monitoring and all that, and of course, in that context, the model can apply anywhere. Yeah, but my question is related to focus. You know, where there are places where people get measles more than in others, and if there is any, what do you call it, strong studies about the cause.
Yeah. Thank you. As I understanding that now the model may work, but the situation will be changed, the outfitting will be different, and that we can get the new parameters also. The rate of change of vaccination may be changed, and as you told the death about the death, measles induced death, we can have the parameters for the delta we have used here.
Yeah, but I assume that you know.
Yeah.
I don't, but I assume that you guys know what percentage of the population anywhere, you can pick anywhere, that get measles, they die.
Oh yeah, we have used in our country, in the context of our country, we have obtained from the reference literature, we have obtained this one from the data too. Not only that, this is now.
But this is high.
Yeah, 0.01. We obtain here, and this is contained. This is this is as the rate per time we have obtained here, but actually this is obtained from the percentage. This is, we calculated this one from the percentage here.
1% per day. 0.01 times your 0.01 times your infection is the number died in that day.
That more year.
So
This
it's
is
not
year.
too much. It's just if 200 people.
Yeah.
I don't know whether it's small or large.
Well,
death. So 200 people out of if 200, how many in Nepal?
600 right now. 600.
600 means roughly is 6 people.
Yes, of course. This is the from that relation, from that the data we obtain this.
Yeah, and just to add your questions, because of this, measles is supposed to be eradicated because the part of great vaccination supposed to be eradicated, but it's coming in. Not only in Nepal, many different places coming in. That's why people are worried about its resurgence, and therefore WHO and also Gates and Melinda Foundation, they actually call the many grants related to global control of the measles recently, actually. So they are really worried about it. It's not like disaster right now, but it's seen frequently, which is supposed to be eradicated, but why it's not? So that's why they are worried.
As an endemic situation, it is now. Endemic. Slowly, it is also shown.
And after like COVID is growing.
Yeah. This is not pandemic. Slowly, a small number, but it outbreaks time by time. This is the interesting, but could not eradicate right now. This is the situation. As observing this situation, we developed another model focusing that's adult vaccination and adult child vaccination, different group. And since there is no adult vaccination till now in Nepal, and also I think in North India, also not so much. This is not so much used for the adult vaccination. And now we develop this model, particularly. First of all, one more thing I forgot to explain, that in our previous model, that actually our population is below 15 and equal as the 15 years up to 15 years. And now we have the population, all the population there. And so we classified this population in the two parts, as the children and the adult. The same as the 15 years and below children, and above 15 years, the adult. And this is we also divide the same as this model for the children is same as previous model, and we extend this model for the adult case here, and we divide, and also we introduce the vaccinated for the adult here. This is the new another parts.
Okay, but the vaccine is the same one that they give the kids?
Sorry?
It's the same vaccine for kids and adults?
See, I have somewhere, I did not see that one, but some paper I have read that the same vaccine is working there now somewhere in Nepal.
I don't think that exists.
Yeah. Yeah.
I think they get the same one, right?
Yeah.
Here also, when we apply for immigration thing, if we don't have the access to do, I think they give the same one.
Yeah. Well, I don't think that exists one. Developed for adults.
Yeah,
Maybe
same, I have somewhere I have read that the same vaccine is used for the adult in Nepal. I have read somewhere that. And therefore we actually this is not used in commonly, is not in program. Therefore we introduce this vaccination for adult, this program we introduce, and we develop the equation as before, and this size is the aging rate. That means after 15 years it becomes the any child is when grow after 15 years it becomes the susceptible if the child is not infected, if the child is infected it comes to this program, and if it is not infected go to the susceptible as others. And the child is recruited by the birth, and the adult is from the aging rate only. This is, and we also divide all these, and this is when on monitor vaccination, on monitor in which child becomes adult, on monitor adult, and they might have the immunized sometime, and they might have infected, and similarly for the child unvaccinated might have the immunized and infected too. And we assume that the monitor vaccination program, this class is, we assume that these are not vaccinated at this time, since it becomes more complicated here to, that's why. Therefore, this is also, and also we introduced the vaccinated program. This is particularly the monitor vaccinated program. It must be. Therefore, this is adult. This is the rate of JI-A, and this is, we assume that this is all are immunized. This is the case since the vaccinated adult vaccinated are when monitored the time, and they vaccinated and they immunized fully. We assume so, and we developed the equation here. And here are 12 equations we developed from the model, and after this model, we also fitted the data from this data as mentioned before. November, this same as 24 to this data, and also this is the map showing that this part is the measles outbreaks. This is, and we use this data. And similarly, we fitted our model to the parameter, to the data, by using this function and minimizing, estimate the parameters, minimizing this function. And this is our fitting with the data and incidence data, perfect fitting is result. This is the cumulative, and we obtain the parameters here also. And these are some parameters fitting, and some are using from others. Some are calculated and some are taken from the literatures, and here also. And we also obtain the mathematically, we also analyze the equilibrium points, stability and bifurcation T here. And this is the disease-free equilibrium point. Here is the case that there are 4 parts are 0. That means child infected, infectious, adult infected, and adult infectious. All those all that's non-zero, so that it makes this little bit complicated here. And we obtain the endemic equilibrium point, and we show that as stability, we obtain that this point is that this is the bifurcation point. RV is equals to 1. We obtain that RV is equals to 1 is the bifurcation point. That's why for RV is less than 1, the disease-free equilibrium point is stable. And for RV is greater than 1, this is unstable, and the endemic equilibrium point is stable. We obtain there is also at least one equilibrium point, and which is stable for RV is greater than 1. And this is the expression for the vaccinated reproduction number, and also this is the effective reproduction number. It depends upon the time. Over the time, the population changes, and the reproduction number also changes. And we similarly, as in the previous model, we also prove the local stability and global stability too. Now, these are our numerical analysis. We also obtain the sensitivity of the parameters to the RV from the local and global. And these are also for the difference as the adult, child, and the combined. And clearly we can see that the adult vaccination, adult is influenced, the RV of adult is influenced by the adult beta. That means adult transmission rate, and similarly this is by the child, and but the commonly as combined the child transmission rate is more influence the RV. And similarly, this is the case for peak infection as before, and peak infection and peak time also we have also done this one, same thing. And this is the impact of the contact network on infection. That means how much population can extend. That means what is the contact network can increase the infection. This is the data here. Somehow these are some points were mentioned here. This one, if the contact network is increased by 5 times, the total infection in children is 4 times, and total infection in adult is 20 times, and double in combined is 8 times. And similarly for all those, yes, we have obtained here this one similarly. And these are the impact of the monitor vaccine program on disease increase or decrease strain. That means disease increase or decrease strain determined by the effective reproduction number. Therefore, all these are the effective reproduction number, and these from this we cannot see. That's why I've written here this one. This vaccination may not be, we can see that the adult vaccination may not be sufficient to reduce the effective reproduction number below 1 within a reasonable time frame. The vaccination coverage of over 90% among the children within the 2 weeks decreases the effective reproduction number is less than 1 in just 2 weeks. This is the relation. That's one. This is more important is here. Children vaccination can reduce the RV less than 1. In contrast, when it is limited only for the 20%, this critical threshold is reached only after the 6 weeks. It takes a long time if there is only a few child are vaccinated. We obtain this one. And this is the impact of the monitor vaccine program on the reduction of total measles cases here also. This is the cases that, this is the case for the adult, and this is for children, and this is for the combined case. And overall, the adult has only the 12% can be changes, and here is the for the case children in 90%, and overall this is also hit in 90% too. And in combined case also the same. And this is the total measles cases. And this is the weekly maximum measles cases here also in the same way. And now there is the, from all this relation, we can, all these analysis, we can say that the measles vaccination, adult vaccination, we cannot see the great impact in the eradication or great impact in the control of the disease burden in the with the adult vaccination. But so that means that in this relation, so we analyze deeply here, as since the all these analysis shows that the adult focused vaccination has only a minimum, only a negligible benefit to reduce the disease, but it has the main impact. That's why, due to the case, we cannot. So in this situation, that the until the large rate of vaccine, child vaccine may child vaccine can may child vaccine cannot reduce the RV less than 1 due to the persistency of infection in adult. And that's why therefore in this situation, this small case of adult, even though we have the only a small cases of adult, since we have also in data there are only 14 cases among the 86% are in child. In these cases, only a few adult works as a seed of the disease to transmit the others. That's one. Therefore, we can say that until this large number of the child vaccine cannot cannot eradicate the disease due to the presence of the vaccine adult cases. Therefore, for this, it's better to eradicate the disease, especially adult vaccine is more important together with the children vaccines. Since there are the presence of the adult vaccines, presence of the adult persistency, presence of the adult infection that can transmit to others and then spread the disease. Though it has not some more impact in the case of in the disease burden, in the reduction of the disease burden, but it is more important to eradicate the disease. Therefore, since it works as a reservoir or as a seed as to spread the disease, therefore, this is the very important parts of our analysis of our work here. And therefore, this is the case that so we from this relation we can say that from this analysis we can say that together with the child vaccination, together along with the adult vaccination may reduce the can eradicate the disease. That is the importance. And now from this analysis, this is our conclusion. Here are some conclusion, and shows that this is the RV, that means vaccinated reproduction number, which is higher than 1, and indicating that so the effort need to be the vaccination program in Nepal to meet the eradication goal. And adult vaccination level required in combination with partially successful children vaccination program to bring RV less than 1. Analysis of contact network also, we found that increasing contact networks increases the total and weekly measles cases in children and adults. Results highlight the importance of adult vaccination, which lowers the adult susceptible population and thereby reducing the infection. And model helps identify a reasonable level of child-adult vaccine coverage to ensure that the decreasing trend of the measles. And the measles cases in adult groups, albeit small in number, act as a reservoir for the measles virus. Therefore, it is important to eradicate the disease, not to reduce the volume, though it has not so much role in the reduction of the disease, but it has the important role to eradicate the disease. And here are some references. And I would like to thanks to my donor as a financial support for IMU and our Nepal Mathematical Society in Nepal, National Science Foundation, NSF, for this grant, and University Grant Commission, and my own institutes. And this is our teamwork. I fortunate here, and my supervisors, and with my two colleagues, we have recently finished. We three have recently finished our work, and we are thankful to this. And as working together, we five formed as a mathematical biology research group, and which is finally formed as a mathematical biology research center Nepal, and working in this way, and also going to organize a national conference in Pokhara. This is for your kind information. I'd like to invite to all of you in this beautiful Pokhara, Nepal, and this now. Thank you. This is from
Now questions. Yes.
So in your map, when you see the geographical distribution of the outbreak, I see it's happening in the border. Indian border, right? If you go back.
India border.
India border, right? So is it because of transmission from India?
I have seen there are some cases also here, but that is not recorded there at that time. Yes. Somewhere I have studied in some paper also. That is also.
So it may be because of transmission, or is it because they don't have access to vaccine in that region?
Oh, mostly they do not want to. They do not want more, especially some regional religious barriers. Some of them may have the low healthcare consciousness, and some of them may have the skepticism for the virus, and that's why they may have some. And also later on, this particularly in this case, that is the disturbances of the immunization program, particularly due to the situation of the COVID pandemic.
I know you had, I think, 20 data points, I think was in the first model. I was curious to know any considerations you made with regard to data points and the number of parameters that you were fitting, and any uncertainty within that.
Sorry, please.
Basically, the amount of data points that you have is similar to the number of parameters you have. And I was just curious what kind of steps you took to mitigate some of that risk that implies in your predictions.
We have only 20 points at that time. We could not get more.
How many parameters you fit?
Oh, we at that time 4 or 5. We also test the rank 2 and also identify take the identification of the parameters also. Yes, we have also this one. Yeah, that's a good question.
That's a very good point.
Good question. Thank you for that. Similarly, we have also restricted there, since there are only among the 7:5:1 or 7:1.
I saw that you assumed some, which I was assuming like that would help with the fitting and the uncertainty, but I was just curious what kind of those steps. But yeah, thank you.
Yes.
So, as a model, it looks very complicated to me. But I'm wondering if you had done like an ablation study where you try to take parts of the model out and see if it still fits the data well.
What was nice?
So your model looks very complicated.
Yeah.
If you have taken some parts of, taken some simplified model, and can you still fit the data? That's a big thing, right?
Of course, that
Rather
might
than
be,
taking
but
some parts out,
yeah.
let's say simplified version. Do you have to take this complicated?
Yeah.
That's his question.
Yes, so that might be also that we have tried so many models with this data too, and also try to and the parameter reasonable parameters and the best fit and since the data itself is very scattered data that this is the and the equation is separated non-linear such type of data, and it is little bit hard, so especially particularly in this whole work the data fitting is very tedious and very difficult to work at that time. It takes a long time to obtain the best parameter and best fit too. Therefore, the simple model may use, we can also, but that cannot interpret our situation. The model can be fitted, but the situation, that model cannot describe our main situation in our main real scenario. That is the main problem.
Yeah, okay.
Okay.
More question. Is there any questions?
Please.
No question.
So I'm not following now, after they see there is a rise after the COVID, are government doing anything now or just don't care?
Right now.
Yeah.
Right
Are
now.
they doing some
No.
new, because they saw that after the COVID is growing and measles is a case globally. So then are they changing anything,
No.
doing anything, focusing on those community, or are they just done?
I haven't got any information about that
Yeah.
one. As I know, that still is the programming is going on as a immunization, regular immunization programming, as a national immunization program is still there working. At that time, that was the obstacle and that disturbances, and now the work is already going on.
Okay, any more questions?
Thank you.
Thank you.